All right, so we're going to switch gears from that just a little bit and move into things where surgery might play a role. And we're going to start. I'm a primarily abdominal surgeon, so we're going to be focusing mostly on the GI tract and then working our way down that as we go. Let's see, where do I want to point this? I guess right here. We'll go through a general overview of gastrointestinal pancreatic, or stomach, intestine, pancreas, neuroendocrine tumors. And then we'll talk a little bit about cytoreduction of the liver, removing, debulking is another term for it.
Just got your timer.
Oh, outstanding. Maybe? Okay. But I don't want to take too much of Dr. Maluccio's thunder, so she's going to be speaking a little bit to that, I believe, a little bit later. As far as, I think it's skipping slides. There, no? Okay. Disclosures, vice chair of the NCCN panel for neuroendocrine tumors, but the content is my own interpretation of the data, so don't take this as gospel from the NCCN. Okay. So as mentioned before, neuroendocrine tumors are a wide variety of tumors. They can develop essentially anywhere in the body. Some of them are hormone secreting. They can cause different symptoms depending on the hormone that's being secreted. So hormones that are from the pancreas can cause different symptoms than hormones that are from the gut or hormones that are even from tumors in your neck. They can be have a number of different names: carcinoid tumors, pancreatic islet cell tumors, medullary thyroid cancers, pheochromocytomas. These are all examples of neuroendocrine tumors. We talked about the incident. So incidences, if you look at within a year, how many new cases are going to be diagnosed versus the prevalence, which is how many are at any given time across the United States. So although they meet the definition for a rare tumor, because there's not very many new ones being diagnosed every year, thankfully people live a long time with them. So if you get 10,000 new cases a year, then they live 20 years, then all of a sudden you have 200,000 people, right? So it adds up over time. It is the second most common cause of liver metastasis to the liver, and so that plays a role in what I do. The most common sites vary a little bit depending on where you are. In the United States, the most common site is now the rectum, followed by the small intestine and the pancreas. And that those general ones kind of flip-flop, you can see here, between different countries when you look at the data, but there usually going to be some combination of small intestine, pancreas, and then colon or rectum in the top three. That rising incidence, you can see here, this is a study that looked from the 1970s to 2012. This was published 5 years later, showing that sevenfold increase since the 70s. So there's just 7 per 100,000 people are now getting diagnosed with neuroendocrine tumor, and that is an increase across all stages and all tumor sites. Now, the interesting thing that occurred during that exact same time is the increase and rise in CAT scan use. So the CT scanner was first designed in the late 70s and put into widespread use in the 80s. And as more places started getting CT scans, more people started getting CAT scan, and we started finding more and more tumors. And that lines up almost exactly with that rise in incidence of neuroendocrine tumors. And so I think what we're finding when we look at the data is that we're finding more. It's not necessarily, although it is possible that we are seeing more neuroendocrine tumors develop because of some environmental changes. It's also definitely a component that we're catching more of these neuroendocrine tumors that we otherwise wouldn't have known about because more and more people are getting CAT scans. So we're seeing the biggest rise in the finding of these tumors are in the ones that are very early stage 1, and still within the organ that they started in. They hadn't spread yet, right? So it's very possible that if we go back to the 1950s, we still had this same number of neuroendocrine tumors. We just didn't know it. You lived your whole life, you never knew you had it, you died of a heart attack, but you had a neuroendocrine tumor. It was just hanging out in there for 20 years. So we don't know the relevance, the clinical worry that is associated with some of these very early tumors. So just to remind everybody, because we're going to be talking about some anatomy here, this is the anatomy of the abdomen. Food comes down the swallow tube, the esophagus, drains into the stomach where the food mixes around, leaves out the first part of your small intestine, the duodenum, empties into the small intestine, goes through that until it gets to the large intestine, and then it comes out your bottom. Hanging off the bottom of the large intestine is the appendix, and then tucked behind the stomach is the pancreas. The liver lives up over the top of it up here in the right upper part of your belly. And each of these organs does different things, and each one of these organs can get neuroendocrine tumors in them. So we're going to start with my favorite organ, which is the pancreas. So it lives behind the stomach, like I mentioned. It has a number of roles. It makes hormones like insulin to help you regulate your blood sugar. And then it makes a digestive fluid called pancreas juice, and that gets pumped down a tube system through the pancreas into the intestines where it mixes with your food to help you digest it. It lives on top of some real high-priced real estate. There's a lot of large blood vessels around there that are responsible for delivering blood to all the organs of the abdomen. And so surgery on this organ can be quite challenging and can have a number of complications associated with it. So we really try to reserve operating on the pancreas until we absolutely have to. As mentioned, it makes this pancreas juice. It makes quite a bit of it, up to 1.5 liters a day. So your body will reabsorb a lot of that fluid, and it kind of gets recycled, but it can make quite a bit of fluid. The stuff that's in that fluid will help break down your food, fats, proteins, and sugars. So if you're not making enough of that fluid, then you don't break the food down. And so you can eat and eat and eat, and it doesn't get digested completely, and you notice that in the toilet, right? So you may notice that a lot of fat comes out, that there's a lot of oil on the top of the toilet. If there's a lot of fat in the poop, then it floats, or it can stick to the side of the toilet bowl and you have to flush it a bunch to get it down. Those are all signs that you may not be processing fats, and that could be because you're not making enough pancreatic juice, or the juice is not getting into the intestine where it belongs because it's being blocked by something like a tumor. It also makes hormones, and all these hormones can be made, they're made normally in something called the islets, which is a part of the pancreas. The pancreas you can kind of think of as a mix of different little communities living together. There's some that are making hormones, and right next door are the ones that are making the juice, and they all kind of live together and commingle. But the hormone-producing cells are these things called islet cells, and those islet cells are what turn into neuroendocrine tumors. That when things go wrong with the juice-producing cells or the acinar cells or the tube system cells, those all turn into different types of cancer, and those are the ones you usually hear of when people say pancreas cancer. Those are cancers arriving from those, coming from those other types of tumor, or this other type of pancreas cells. Islet cells are the ones that turn into neuroendocrine tumors. They're a relatively rare pancreas tumor, but we saw that for neuroendocrine tumors, they're the second or third most common. They can cause symptoms related to any one of the hormones that the pancreas produces. So if it makes too much insulin, then you're going to see people's blood sugars drop. If it makes too much glucagon, which is the anti-insulin, you're going to see your blood sugars too high. If it makes some of the other hormones like VIP, somatostatin, gastrin, you can have different symptoms associated with that. We'll talk a little bit about that in a second. But the hormone-producing types of these tumors are the least common type. It is much more common to have one that is not producing a hormone, or at least not producing a hormone to a level that your body notices. If we go and check certain blood levels, maybe they're a little bit high, but they're not causing any kind of symptoms. So as Dr. Gupta mentioned, we don't usually go and check all these hormone levels in your blood because they can be elevated for other reasons, medications you're on, other medical problems you have, or sometimes they're just elevated because you just ate. It depends. So we don't usually check these unless you have a symptom, and then we check them to kind of confirm what we already suspect. Not all of them are cancers. So as I mentioned, there are some of these small neuroendocrine tumors that we find that we know people will live their entire lives with and never cause any trouble. So there are a subset of these tumors that are probably never going to be a problem. The issue is that we don't know how to determine that very well. We use a lot of things that, on the CAT scan that helps us kind of guess if this is going to be an aggressive type. How fast is it growing? How big is it? And we'll talk a little bit about that too. But there's a chance that it's, even if it has those features that we're worried about, it's never going to cause a problem. So I think until we get good molecular markers, genetic markers, things that really let us tell us how aggressive these tumors are going to be, we're stuck with just looking at CAT scans and following. They can be associated with certain different inherited syndromes. The two most common are MEN1 and von Hippel-Lindau. So who needs a resection? So I think people who are symptomatic, if you have a tumor, regardless of the size, if it's secreting a hormone and causing you trouble, we typically recommend removing it if you're able to tolerate the operation, it's a safe operation. The trick kind of comes down to people who don't have symptoms from it. So if it's a non-functional tumor, something that's not making hormones, as I mentioned before, not all of those are going to end up causing a problem. They aren't capable of spreading, they don't go to other organs, so therefore they're not really a cancer. They can grow and they can cause problems with being certain sizes, but if they're not causing a symptom, what do we do with it? These are a list of all the different, or at least the most common hormones that the pancreas makes. Most of these hormone-producing ones do have the potential for becoming a true cancer, meaning they can spread to other organs. So we recommend removing them both because they're symptomatic and because they're malignant potential. The weird one there is the insulinoma. Those ones are very unlikely to spread to other organs. So therefore, we don't really consider them to be a true cancer. And that changes a little bit how we treat it, and we'll talk about that in a second. So when we're looking at these, what we call asymptomatic, meaning you don't have a symptom from it, non-functional tumors, who gets a resection? Who gets it removed? So the best evidence we have to predict who's going to have trouble with these is the size. So there's been a number of studies, and this is a study where they pooled all of those other studies together and they looked at it, and they looked at a couple factors that we look at, and they say, okay, if we were to take out this tumor in somebody, what is the chances that a tumor with this characteristic has spread to a lymph node? And if this tumor is spread and it's set up somewhere else in your body, then we consider it a cancerous type, right? It's able to it started somewhere and it spread somewhere. That's a cancer. And if we look at the size is a really good predictor of it becoming malignant, meaning a cancer. So if it's less than 2 centimeters, the chance of it spreading to a lymph node at the time of resection is less than 10%. If it's less than 1 centimeter size, it's less than 5%. So we typically recommend just watching those until we get over this magic 2 centimeters where the risk of it spreading goes up to 40% or more. So we say, okay, probably time to take it out because this is a higher chance of this being a cancer type. The grade that Dr. Gupta talked about as well, the higher the grade, the higher the risk. The location in the pancreas doesn't matter as much if it's on the left side or the right side. And then this data down here is a little bit interesting, and there's been some other studies that have come out since, which is is this a solid tumor, or does it have a almost fluid-like substance in the center, what we call a cyst? And the cystic type seems like are probably a little bit protective, meaning they're lower risk, even size for size. There we go. We're going to talk about that. The other interesting thing, and this is data that came out of our group here, is that your ancestry may play a role in this too. So we looked at 2 large data sets, a large consortium of 11 different centers, and then validated this in a large national data set of quite a number of patients, and looked at, well, if we looked at that exact same tumor with the same size, if you had African ancestry or European ancestry, what was the risk of it going to a lymph node? And it turns out that for a 2 centimeter tumor, ones that we would normally recommend just watching, if you have African ancestry, you are up to 2 to 3 times higher risk of it spreading to a lymph node than if you have European ancestry. And so this has made its way into the guidelines now as a consideration for that kind of 1 to 2 centimeter gray zone. Like, what do we do with it? Should we watch it? Should we offer an operation? Should we maybe watch it a little bit closer? So that's just a different thing that plays in to our algorithm on how to advise patients. Oop, going too far. Another thing that came out recently was calcifications. So when I started, I used to think, if I saw a tumor with some calcifications in it, meaning it had little stones in it, that means it's been there for a while. It's almost like it's been petrified. So that's a good sign, right? It's been there for a while, probably doesn't cause any trouble. Well, it turns out that's actually the opposite. So the calcifications actually may be a bad sign, and people who have calcifications seem to have a more aggressive disease. So when we look at this risk of, we're trying to offer an operation or recommend an operation to somebody, we're going off of that size, and we feel pretty confident that if it's less than 1 centimeter, it's probably pretty low risk, we can watch it. If it's greater than 2 centimeters, it's probably a higher risk, we should take it out. But that 1 to 2 centimeter zone is where things get a little bit gray. And we look at things like, does it have a solid or a fluid-filled component? What is the rate of growth? Does it have calcium in it, calcifications in it? What's your ancestry? And then we can advise people and say, okay, do we want to watch this? We want to watch this a little bit closer instead of every year, maybe every 6 months? Or is this something, you're 40, you're not really willing to take that risk, you don't want to watch it for another 30 years, it's an easy operation, maybe we should just take it out. But not all operations on the pancreas are the same. So depending on where your tumor is, the operation can be lower risk or very high risk. There's a number of different operations that we perform for these tumors, and we're going to go through some of those right now. So one thing to talk about before we do that is we tend to design cancer operations, one around the blood supply to the organ, because if we're going to take a part of the organ out, we need to make sure that there's enough blood supply left to the part that's remaining that it's going to survive. So we base a lot of our operations around blood supply. And for cancer in particular, we design our operations around lymph nodes. So we know that cancer, one of the first places that this tumor can spread to is a lymph node. So if we want to take the tumor out, then we want to make sure we can get all those lymph nodes out around it that could have tumor in it. So if we're doing an operation that could be for cancer, now there's a little bit of a difference in the surgical community around this on neuroendocrine tumors, but my belief is that if we're doing a cancer operation because we think this is a cancer, I'm going to do a cancer operation and I'm going to take out the lymph nodes. And so I designed that operation around that. So for a tumor that's over here on the left side of the pancreas, we'll do something called a distal pancreatectomy, sometimes plus or minus a splenectomy. And if I'm doing this operation because I think there could be a cancer in there, I'm taking your spleen. That's my interpretation of the data, and that's what I do. Because the lymph nodes that live around the spleen could have cancer in them, and I want them out. That I will often do minimally invasively, and I think most surgeons will do that, but there may be indications for doing this as a bigger open operation too. For tumors that are very small tumors, or in my opinion on this is really the only one that we should be doing this for is an insulinoma, because that very low risk of it spreading is an enucleation. So that's, if it's just hanging off the edge of the pancreas, you can just carve it out, right? Just take it out. And I think that's suitable for an insulinoma because we know that it's a very low risk of spreading. But if we're doing this for something that has a 40% chance of going to lymph nodes and you're just carving it off the edge of the pancreas, you're still leaving all those lymph nodes behind. So I don't do this except for insulinomas. Now, the big gun for pancreas surgery is the Whipple procedure. And I think some of you have heard that. This ends up being synonymous or a catch-all term for pancreas cancer, or for pancreas surgery. And everybody who comes to me thinks they're getting a Whipple. That's not true. It depends on where in the pancreas your lesion is, which operation you're going to get. But the Whipple is for tumors that are on the right side of the pancreas. And this is a big operation. It's one of the biggest things we do to people. And it involves removing the right side of the pancreas, the first part of your small intestine, plus or minus part of your stomach, your gallbladder if you still have it, and part of your bile duct, and then reconnecting everything. And then each one of those connections has a potential for leaking. So, there can be a number of things that can go wrong with this operation. So we really reserve it for people we think it's going to be a big benefit for. So let's move on down the GI track. So that we'll start with the stomach. The stomach also can develop neuroendocrine tumors. These are kind of broken down into different types, and there's actually probably going to be a type 4 soon. But type 1s are usually small, little tumors. We typically manage that endoscopically, so the gastroenterologist will go in and kind of scrape them out from the inside, and we just surveil those. They have a pretty low chance of turning into any true cancer. as long as they stay sub 2 centimeters. If they get bigger than 2 centimeters, then we start talking about an actual operation to remove part of your stomach and the lymph nodes. Type 2 tumors are related to a pancreas neuroendocrine tumor that secretes something called gastrin. You get the syndrome is called Zollinger-Ellison syndrome, ZES, you may have heard of it called that. Typically a really bad heartburn, high acid, but that as a side effect creates neuroendocrine tumors in the stomach. Those are a side effect of your pancreas tumor, so the treatment for those is take out your pancreas tumor. And then the type 3 are typically single, solitary, larger neuroendocrine tumors, and those ones are risky. And those ones we typically will recommend removing within a cancer operation or removing part of the stomach and the lymph nodes. The stomach removal can be done in different ways. Again, if it's in the lower part of the stomach, we take that part. If it's in the upper part of the stomach, then there is a difference in opinion here. In Asia, it's more common to just take the upper part of the stomach and then sew the lower part of the stomach up to the swallow tube, which is called a proximal gastrectomy. That has not worked out so well in the United States. The symptoms from that with horrible reflux disease is pretty bad, so I don't do that operation. If it's up in the upper part of the stomach, you lose your whole stomach. And then we just hook the small intestine up to the esophagus, and it ends up being like a pretty drastic gastric bypass, but you can eat normal food and you maintain your weight. You just have to eat more frequently. If we go on down to that first part of your small intestine and the duodenum, these ones, again, if they're small, the endoscopist can manage these. They can remove them endoscopically through the GI tract. There's an example of this where they inject some fluid underneath it, lift it up away from the deeper layers of the intestine, and then scrape it out. And we typically will favor that, but sometimes these things can be quite large, and as they get larger, their risk of spreading the lymph nodes goes up. In fact, the risk of it going to lymph nodes in the 1 to 2 centimeter range is probably higher than the pancreas, and so, we have to tailor our recommendations for operations here, because depending on its location, the operation could be we just remove part of the intestine, or we do the Whipple procedure. So it can be a big difference in which operation you're offered depending on where this thing is located. Small intestine, so you'll see this theme of 2 centimeters repeating itself over and over and over again, except for small bowel. All bets are out the window on this one. You can have incredibly tiny small bowel tumors that have taken over your liver. I mean, they spread at any size, and they have just a different biology that we don't fully understand. Half of the time, there's going to be more than one of these in the small intestine. So we typically will recommend doing this, removing these at any size if possible, and doing that through an open operation, not laparoscopically, because I like to be able to feel the intestine to find that second tumor. You can miss those pretty significantly on laparoscopic operations, and then you end up having another operation in the future potentially. They can cause blockages, pain, significant diarrhea, that carcinoid syndrome that most of you probably are familiar with. When people have spread disease, we typically will recommend removing their gallbladder at the time of that operation, because you're going to be on that somatostatin analog, the lanreotide or the octreotide, and that develops gallstones and requires gallbladder removal about 20 to 30% of the time. So if we're already operating and you're going to need a gallbladder surgery in the future, we'll typically recommend removing your gallbladder at the time. This is an example of one of those tumors. This is the dotatate PET scan. This is making that tumor light up. And this is not the tumor that's in the small intestine. This is a tumor that is probably spread to a lymph node and taken over that lymph node. And so that's very common to find. We'll find this, we'll see this thing that's in the mesentery, or the kind of blood supply to the small intestine, that is a neuroendocrine tumor. And that's not the original tumor you're seeing on the scan. That's where it's spread to. The original tumor is probably some tiny little thing hiding out in your small intestine, and now it's spread to this lymph node and taken it over, and that's what we're seeing. Oh, no, went too far. Maybe his battery's dead or something. All right. well, I guess we're going here. Okay, neuroendocrine tumors also are one of the few cancers that we recommend sometimes for people to have spread disease removed. So many cancers, once you're stage 4 and it's spread to other organs, we don't offer an operation. We give you systemic therapy, chemotherapy, immunotherapy, but usually not surgery. Neuroendocrine tumors are a little bit different because they can be very slow growing, and there's been some studies that have shown some significant survival benefit and then reduction in symptoms for people who have disease that has spread to their liver and sometimes within the cavity of their body. And we can recommend operations to remove that if we can get a certain percentage of that out. We just think there's a survival benefit, and that seems to be 70%. We will even recommend bowel resection in people who have metastatic disease. Maybe even their liver is not, we are not able to get it down below that 70% threshold, but by removing the primary tumor, the small bowel tumor, we can prevent blockages, we can have improvement of symptoms, and prevent an additional operation in the future. For appendiceal cancers, so that first part of the appendix there, these are often found incidentally. You get an appendectomy because you're told you have appendicitis, and when they look under the microscope, turns out there was a neuroendocrine tumor in there. Most of the time, they're very small. The appendectomy is all you need. But if they are large, and sometimes we find this ahead of time, then the current recommendation is to do a formal cancer operation, again, based on the blood supply and the lymph nodes, and that means moving the last part of your small intestine, the first part of your large intestine. The 1 to 2 centimeter zone is a tailored approach. There was a paper that came out of Europe about 2 years ago that is questioning that. My personal opinion is that it was not a good paper, and I don't think it changes guidelines at all. We've been dragging our feet at the NCCN on that because of it, but I still think in a 1 to 2 centimeter, whether or not you need to have an additional bigger operation depends on a number of factors about, like, did we get all the tumor out? Was it in a lymph node? How old are you? What is the grade? That kind of thing. And so I think it's a discussion with the patient. Liver tumor removal, which will be covered more here in a second. Typically, if you're having symptoms, if we think we can get over 70% of the disease, because it may have a survival advantage and it can help improve symptoms if you're having bad carcinoid. And you can reduce, if you can get rid of a lot of that tumor bulk, then it may be easier to treat the additional tumor that is in the liver with other things, interventional radiology techniques like TACE or Y90, PRT, Lutathera, or even potentially ablations. But you have to be careful of burning things in the liver if you've had a Whipple, because you can get bad infections. This is an example of one of my residents and I taking out a neuroendocrine tumor from the liver. All right, I think, in summary, not all neuroendocrine tumors need to come out. In general, greater than 2 centimeter tumors are riskier. Surgery may make sense even if it's stage 4 disease or it's spread to other organs. Less invasive approaches may be an option for some people. And as you're going to hear a theme today, see a specialist given how uncommon these tumors are. And we're happy to see you here in Birmingham. Thank you.